All right, this is looking good. I am just gonna start getting started with introducing this webinar series, and then we'll get into the content. First, hello and welcome. This is a new webinar series we're putting together at OmegaQuant's called Nutrition Talks. This is our first in a series of monthly webinars aimed at providing current research and education to our healthcare practitioner partners. My name is Christina Jackson. I am the Chief Operating Officer at OmegaQuant, but I'm also a registered dietitian and a PhD in nutritional sciences. Our presentation today, however, is given by Kelly Patterson. She's a registered dietitian and she's our Clinical Nutrition Educator at OmegaQuant. And as you can see, the title is the Omega-3 Index and Cardiovascular Disease. So I want to give a little background about Kelly. Kelly is a registered dietitian and a certified specialist in sports dietetics. She's based in North Carolina. She spent most of her career working for the U.S. Army, including 5 years as a tactical performance dietitian for an elite special operations unit at Fort Bragg in North Carolina. And it was during this time she developed a passion for measuring and monitoring nutritional biomarkers, specifically those related to traumatic brain injury. And omega-3s and the omega-3 index are where she found the omega-3 index. Kelly came to OmegaQuant in 2021 to further her work in the omega-3 space and to help OmegaQuant expand their testing options. She completed her undergraduate education and dietetic internship at SUNY Buffalo State College in Buffalo, New York, and later completed her master's degree in human performance and sports nutrition at Logan University in Chesterfield, Missouri. So for how this is going to work, the presentation will be an hour with 10 to 15 minutes reserved for questions at the end. So you can type any and all questions into the Q&A box. Preferably, there's also the chat box, which should be more for if you have an audio issue or something like that we can address. But we'll look for the questions wherever we can find them. This webinar is eligible for 1 CE credit for RDs and DTRs, and we will email certificates to those who attend the full webinar. If you have any other questions, again, please put those in the chat box or the Q&A box if it's a question for Kelly. Thank you all for attending today, and I will turn it over to Kelly.
Thanks so much, Christina, and welcome everybody. Thanks for that introduction. So I'm going to go ahead and get started and dive right in so we can maximize the time that we've got together. So as Christina stated, today I'm going to be talking about the omega-3 index and cardiovascular disease. So just a little, just to get started, I wanted to give a little background on OmegaQuant, just about us, kind of what gives us the know-how on this topic. So OmegaQuant was established in 2009 by Dr. Bill Harris, and he was one of the inventors, discoverers of the omega-3 index. And so over the past few years, we've been launching some new tests. I'll go over what the omega-3 index and all that is as well. We participate in a lot of research. We also have commercial products for direct to consumers and work with a lot of healthcare providers as well. Our primary focus is on fatty acids, specifically omega-3s, with our kind of flagship test being the omega-3 index. The learning objectives for today's presentation are to identify the role of omega-3 fatty acids in cardiovascular function and their relationship to cardiovascular disease, interpret omega-3 index results, learn a little bit about the omega-3 index, identify patients who would most benefit from having their omega-3 index measured, and monitoring and treating omega-3 index levels as well. This is a presentation geared towards healthcare providers, so just an FYI. So first I'm going to talk a little bit about the omega-3 index itself, then I'm going to go through some research on the omega-3 index in cardiovascular disease. That's going to be kind of the first third of the presentation. Then we're going to go into clinical application, how we can use the omega-3 index in our clinical practice, and case studies as well too towards the end, and then we'll do Q&A. Okay, now we've got all that housekeeping out of the way. So we're going to go with start with what are omega-3s. Most of you are probably familiar generally with omega-3s, but just to establish, omega-3s are polyunsaturated fatty acids with their first double bond on the third carbon from the omega end of the molecule, okay? The human body cannot put a double bond on that omega-3 position, which means that omega-3 fatty acids are essential. We need to consume them in order, we can't produce them. We are able to interconvert some forms of omega-3s, but for the most part, we are not able to produce our own omega-3s, mostly. And the primary focus today, we're going to talk about primarily two omega-3s, which are EPA and DHA, okay? There are several others, but those are the primary ones that we're going to be focusing on today. So I mentioned the omega-3 index several times already. And what is the omega-3 index? The omega-3 index is a measure of the amount of EPA and DHA in red blood cell membranes expressed as a percent of total fatty acids. So in a red blood cell membrane, we have our phospholipid bilayer, so a double thick layer of phospholipids, and these are all different types of fatty acids. There are many different types of fatty acids, and some of them are omega-3s, some of which are being EPA and DHA. So in this particular model, if there are 64 fatty acids in this model membrane, 4 of which are EPA and DHA, so we take a combined number of EPA and DHA, 4 over 64 is 6.25%. So the omega-3 index in this particular example would be 6.25%. Okay, so is it percent, the number expressed as a percentage of EPA and DHA of those phospholipids in that membrane of the red blood cell. And this is a test that we perform at OmegaQuant. I'll talk a little bit later about our tests and how they work, but our most popular and kind of our foundational test is this omega-3 index, measuring this number for folks. So the reason the omega-3 index is really unique is because red blood cells are a stable marker of long-term omega-3 intake. A lot of people may have seen at other labs or larger labs or a hospital may have measured plasma EPA and DHA or plasma omega-3 levels. The big issue with measuring plasma versus a red blood cell is that plasma is a far less stable marker than a red blood cell, meaning that if you were to take your fish oil supplement a few hours before getting your blood measured or blood drawn, or have, salmon the dinner the night before, if you've eaten more fish this week than you normally do, that plasma level is going to be fairly significantly affected, or can be fairly significantly affected, which means if you went on vacation and ate a lot of fish and you don't normally eat that much, if you were to get your blood drawn when you came back, it would look like, oh, you're getting a lot of omega-3s in your diet long term. And so it's just a really unstable marker. Whereas red blood cells, because of the life cycle of red blood cells being that 90 to 120 days, we get a much more extended time period look at how much your omega-3 intake is over time. So even if you had a lot of fish this past week compared to normal, your red blood cell EPA and DHA amount, your omega-3 index won't go up that much. It will only go up in the red blood cells that have been produced in that week, that time span, which isn't most of your red blood cells, right? Because they have that 90 to 120 day life cycle. So it's a much more stable marker and gives us what we really want out of a nutritional biomarker, which is something that reflects our actual intake over a fairly significant period of time, not something that was just yesterday or this past week. The other thing that omega-3 index reflects is changes in dietary omega-3 intakes, which sounds like it would be obvious, but as we in nutrition know, it's not always as easy as saying, well, I eat more of X nutrient, so that will go up in my blood. That's not always the case because there are complex processes and different reactions that may affect that number. The omega-3 index does directly affect increasing omega-3 daily doses. So as we can see here, this is from Journal of the American Heart Association back in 2013, the omega-3 index does directly affect increasing daily doses of omega-3s. So the more omega-3s you take over a period of time, this particular study was over 5 months, the more omega-3s you have, the higher that dose is, the more your omega-3 index will go up. So it's a sensitive marker that will go up with dietary changes, and it's stable. So we can rely on it to show that 3 to 4 month intake level. So what index is a target? What's optimal? What's good? So over the past 20, 30 years, a lot of meta-analyses, epidemiological studies, and control trials have kind of come to a range of ideal when it comes to longevity, cardiovascular disease risk, and sudden cardiac death risk. And we've come to at OmegaQuant that we would the greatest protection is provided between 8% and 12%. Okay, so we'll look at this next slide. So that 8 to 12% is what's desirable. Okay, so what's typical in the US and Europe, and this is varies depending on, especially in Europe, varies depending on country to country, but typical for the US, we're seeing around like the 5 to 5.5%, sometimes even a little bit lower. Certain populations, especially those who are vegan and those who have high amounts of oxidative stress, such as those in like the military, tend to even see lower than that, like 4 to 4.5% being averages. But countries where their fish intake is a lot higher, and specifically fatty fish intake, the kind of golden example, perfect example of this is Japan. Japan, we use as kind of a standard bearer for the omega-3 index. A lot of the early research in omega-3s and in for the omega-3 index was used and done in Japan because they have very low rates of cardiovascular disease and very, very high intakes of omega-3s. They are typically up in the 8, 9, 10%, depending on the region, because of their fish intake. Okay, so again, this is that EP and DHA combined percentage total of fatty acids in that red blood cell. And we really, at OmegaQuant, after looking at all of the research, our desirable level is between 8 and 12%. There is a really big benefit health-wise to getting to that 8% or higher. And we have 12% as being the upper limit because research has shown that beyond 12%, we sort of have the diminishing returns. There doesn't seem to be any negative side effects to being above 12% for the most part. And there also doesn't seem to be any additional benefits. Going up higher to 13, 14, 15% doesn't seem to have any additional benefits. So taking the amount of omega-3s that you would need to get up there is not necessary. So I mentioned Japan and why we use that as kind of a standard bearer. First of all, Japan has a far, far lower rate of death from coronary heart disease. So we're talking about cardiovascular disease here today. Japan has just a far, far lower rate of total mortality from coronary artery disease. And Japan has a much longer longevity. So Japan is like number 2 on the average longevity in the world. The US is down here. Again, this is US based, but we see similar statistics to other kind of Western countries and regions such as Europe, Australia, things like that. All very, very similar because diets can be similar. Again, it can vary depending on region in those areas, depending on the actual country, especially in Europe. And certain places in the United States, but overall, these are the averages. And, besides the omega-3 index being really high in Japan, those averages being above that 8%, closer to that 10 or 12%, it's been shown that their omega-3 intakes are much, much higher. And again, this makes a lot of, obvious common sense. People in Japan eat a lot of fish frequently every day. Really from childhood. So they start with babies and throughout the lifespan. They have a lot of omega-3s on board and a much, much higher lifespan and much lower rate of cardiovascular disease as well. So I'm going to move on to some research. Now that we've covered the basics on the omega-3 index, I'm going to move on to a couple of research studies going over the relationship between the omega-3 index and cardiac disease. There will be cardiac arrest, deaths from cardiac events, and longevity as well too. So this first one here is the King Cardiac Arrest Study. This is one of the foundational studies related to the omega-3 index. This is from the Journal of the American Medical Association back in 1995. And this study really showed that the risk for primary cardiac arrest is inversely related to the omega-3 index. This is here on this graph, you see the quartile mean of the omega-3 index. That 6.5% is the number on the end there. We see the much, much lower risk of a cardiac arrest versus those lower quartiles, so the 3.3 and the 4.3%. In this particular study, the omega-3 indexes, it was a smaller study, only 82 cases experiencing that primary cardiac arrest compared to 108 population-based controls, but seeing a significant relationship between that omega-3 index and the cardiac arrest. Okay, and in this case, it's really important to note that all of the cases and controls were free of known cardiac disease and were not on fish oil supplements. So this is sort of in the wild, influenced. These people were having a higher omega-3 index, probably likely because of lifestyle, mostly their diet, and they had a much less likely incidence, much lower incidence of cardiac arrest and cardiac events. So this next study here, this is a much larger study. This is a risk for sudden cardiac death. And this study is also shows that the risk for sudden cardiac death is inversely related to the omega-3 index. So this is a much larger study, 15,000 male physicians between the ages of 40 and 84. This is, again, older. It was published in 2002, but their data was collected in 1982, and none of these people had a history of CVD or cancer, and they were provided a blood sample. Then 17 years later, there was follow-up, and 94 of these men experienced sudden cardiac death. And these were the statistics on their omega-3 indexes. Again, seeing that higher omega-3 index compared to the lower, there was a significant increase in risk when you have the really low. And 2.7% is a very low omega-3 index, so it's not a surprise that was much more significant. We really kind of chunk the omega-3 index up into, those 4%. We see a big change at 4%. If you can get over 4%, that's a good risk reduction. Over 8% is the best. If you can get over that 8% and getting up towards that 12%, you're kind of maximizing your benefits there. Another study showing the predictor risk for fatal coronary heart disease. So this one, I like this study here because we're showing up to that 8% being beneficial. Go back. So in this case, the risk for fatal coronary heart disease was 35% lower in people with an omega-3 index of 8 compared to those with 4. So in the last few studies, I showed how, in that 4, 5, 6%, you can still see benefit as compared to that 2, 3%, right? So that really low. And what we're seeing here in this study, published in 2017, is that going up to that 8% does provide that additional benefit. And this was a meta-analysis from 10 studies worldwide with over 27,000 subjects. So this is a really large study showing a pretty significant risk reduction in, one of the biggest killers, coronary heart disease, especially here in the United States. So we do see benefit as we increase that omega-3 index. All right, one or two more on these studies, and then we'll get to the clinical application. Okay, this is a study showing relative risk for death from any cause. So those were all cardiovascular disease, cardiovascular events, sudden cardiac death. This is relative risk for death from any cause and the omega-3 index. So all cause mortality, and these are from the Framingham Offspring study. This first group here, this is the omega-3 index, and this is showing that the omega-3 index is actually more predictive of all-cause mortality than cholesterol is. And that is not to say that cholesterol is not an important marker. I don't want to add on to people saying that cholesterol is not important or that we shouldn't be measured or we shouldn't care about cholesterol. Cholesterol is very important and should be measured. But the omega-3 index, when it comes to cardiovascular disease and all-cause mortality, is really, really, really strongly correlated inversely, right? So that those lower numbers, the less than 4%, 5, 6, are all related to higher rates of death from any cause. And this was for 2,500 people that do not have cardiovascular disease at baseline in their 60s, and they were followed for a median of 7 years. So these are longitudinal studies, they're long-term, 7, 10, 20, 30 years, watching folks, again, because of the nature of the condition, and showing that the omega-3 index is actually more strongly correlated than cholesterol. And the last one here, so actually I think I have one more. People with the lowest EPA and DHA are the highest risk of dying prematurely. Putting it really, really simple. This is a little bit smaller of a study done on folks in London, drawn fatty acid levels. Again, this was over time, over the course of 20 years, and those with the lowest EPA levels were most likely to pass away. Same thing with the DHA levels, were most likely to die earlier for any cause in that 20-year span. Okay, so seeing EPA and DHA levels, the omega-3 index, really predictive of those longitudinal outcomes. Omega-3 index levels are inversely linked with again, risk from all-cause mortality. So this is another study from the Framingham cohort showing that the omega-3 index is inversely related with several different conditions as well, but all-cause mortality right here in this first graph. The inverse relationship is very, very clear with the omega-3 index. Okay, so that was just our research section. I wanted to kind of go through that a little bit quickly because my real focus here today is our clinical application, since I know many of you are healthcare providers and want to know how you can put this into practice. And we'll answer a couple of misconceptions, kind of concerns some folks have with the omega-3 index as well. All right, let's go ahead and get started. So the first one here is lipids, cholesterol, and triglycerides. A couple of misconceptions here is, the first one is that, shout it from the rooftops, omega-3 supplements do not lower cholesterol, okay? I've had this case several times where a practitioner or a patient will start taking omega-3s thinking that it will help their cholesterol levels. My doctor said I need to eat healthier, so I started taking fish oil, but my cholesterol didn't budge. Omega-3 supplements and the omega-3 index, it's not going to lower your cholesterol levels. Omega-3s can lower triglycerides in the setting of hypertriglyceridemia. So if we have high triglycerides, taking omega-3s are a well-known established practice that lower triglycerides. And lowering triglycerides, especially if they're really, really high, can help slightly lower total cholesterol because of that formula, total cholesterol being HDL plus LDL and then 20% of triglycerides. That may result in some lowering of that total cholesterol number, but it does not independently affect HDL and LDL. Those are not generally affected individually. Now, sometimes patients who are adding in more fish to their diets might displace some of the sources of saturated fats. They might displace some other items in their diet if they're eating a lot of processed foods, causing some decreases in LDL, which is great. That's a good thing if they're going the dietary route. But supplements on their own without dietary changes are probably not going to lower their cholesterol. In some rare cases, and this is usually only seen in really high doses of fish oil supplements, fish oil supplements can contribute to increases in LDL cholesterol in and of itself. Those are typically in rare cases if somebody is already on a high-fat diet, or if they're taking really, really high doses of omega-3s, sometimes you can see that raise in LDL. So if you see that in a patient, it could be related to the amount of fish oil they're taking. That could be something to look into, but it could also be their diet and be completely unrelated if they're taking a supplement as well. That's why diet is super, super important. Although supplements are great, we always want to look at things holistically. All right, so I'm going to go through a couple lipid panel examples here. The first one here, we're just going to simple, would omega-3s help here? This person has a slightly high cholesterol, nothing crazy, but really the biggest number that jumps out there is the LDL of 120. Their total is 204. Their triglycerides are awesome. HDL is pretty good. VLDL is all right, but that LDL is 120. And in this case, omega-3s, in terms of the actual supplements, are not really going to help here. However, this person now has a cardiovascular risk factor. They have the elevated VLDL and the elevated LDL. So checking their omega-3 index would be a really good kind of adjunct thing to do. It would be a good additional risk marker to see where they're at, and trying to get them to between 8 and 12%. Just because using omega-3s might not treat their cholesterol, if we think back to that study that showed that the omega-3 index is actually more predictive of all-cause mortality than cholesterol, we would want to check that omega-3 index too, because they've already got a risk factor. But treating that LDL on its own is what would be necessary here, but also adding in that omega-3 index, checking that, and then trying to get them up to that 8 to 12%. And the LDL can be treated, diet, activity, meds if they needed it. They're still not crazy high there, so probably wouldn't qualify for medication at that point. So the next one here, a lipid panel, would omega-3s help here? So this person has a little bit higher of a total cholesterol, but their triglycerides are 201 and their LDL is 170. So this should be highlighted red here, this 201, definitely. And their HDL is kind of on the low side as well. Not super low, but depending on, the person. So yes, in this case, triglycerides, an omega-3 supplement would help, but they'd also be a really good candidate for making sure you check their omega-3 index. I think we should, it's really important. We believe here at OmegaQuant, kind of our philosophy is you can't manage what you don't measure. So just throwing some omega-3 supplements at somebody for triglycerides and hoping we're getting the dosage right and hoping we're getting the numbers right, it's really flying in the dark and flying blind. If you can measure their omega-3 index, find out where they are, and then dose appropriately and remeasure and get them into that space of that 8 to 12%, you're going to be much more effective, have much better outcomes. Okay. It's probably not going to do much for their LDL, but even if they don't do a supplementation here, this person could probably benefit tremendously from some dietary changes as well. Okay, so this is a topic of conversation that has come up really recently. There was a little bit of media in the last few years regarding irregular rhythms, so AFib, atrial fibrillation, and omega-3. So specifically omega-3 supplements. We recommend omega-3 supplements to a lot of people, so we want to make sure that we're not, recommending something that could have potentially an unintended consequence. There's really, really mixed evidence on risk for AFib and omega-3 supplementation. There have been several prospective cohort studies in the last several years that have shown an increased risk of AFib with about a gram of daily fish oil use. So those studies are out there, but it does appear that risk is greatest in those who already have cardiovascular disease. So one of the things we know, and that is kind of emerging through evidence, is that omega-3s are really, really, really effective as a preventative measure. And that would line up really well with kind of all the evidence and research coming out of Japan, seeing that these are things, omega-3s are something that's in their diet for the entirety of their lifespan, not something that that's just being thrown at them or encouraged for them to eat when they get older. So it doesn't mean if you have patients who are older that it's not beneficial to get them to eat omega-3s or take omega-3s. But the younger we can start these habits as preventative measures, the more effective they are and the less risk they carry. The other thing that's really important to note is that risk did not appear to be associated at all with omega-3 intakes from food. So it's just supplements. And it just seems to be in this one population that have already been diagnosed with CVD that are taking these higher doses of fish oil. So if you have a patient like that and you want to put them on maybe a little bit lower dose of an omega-3 to avoid that risk, encourage them to start eating more fatty fish. That will reduce the risk, and it will also help them absorb those omega-3s. And we'll talk about that in a little bit. Okay. So there is some. However, on the flip side, there have been a couple other studies that have shown no risk for AFib or atrial fibrillation with regard to omega-3 supplementation. This is the Vital Rhythm study. It was the largest primary prevention AFib randomized control trial with 25,000 participants ages 50 and older, and they were followed for 5 years. This can be a shorter study because, again, AFib is a bit more short term of an outcome. They're not looking for something like total longevity. These people were given 1 gram of omega-3s versus a placebo, and there was no significant difference in AFib rates between the omega-3 group and placebo. You can see that there was a little bit increase of that AFib, but it was not statistically significant. So effectively, there still really seems to be, and this was a very, very, very large trial. So it seems to be that the EPA and DHA may not have an effect. So that's why I say, we still feel pretty comfortable recommending those higher doses of omega-3s for most folks, but people who might be at most risk are probably a little bit older, probably have slightly more health risks. If somebody already has AFib or already has a diagnosis of CVD, we might want to look at other options. Bleeding risk. So this is another concern that some providers have with, especially some higher doses of fish oil, is bleeding risk. Especially surgeons tend to get a lot of concern. Obviously, they don't want to have patients bleeding out on them. It's been a healthcare concern or concern of healthcare providers for a long time, especially at those higher doses. But I think we can pretty much say that this has been proven to be not true pretty well. So there have been several studies. One of the most recent one here is the OPERA trial, published in 2018 in Circulation, 1,500 patients across 3 countries. It was a placebo-controlled, double-blinded study. Patients received 8 to 10 grams a day of fish oil. So we're not talking about 1 gram or 2 grams or 5 grams, really high doses of fish oil preoperatively, and 2 grams a day post-op. So these were pretty high doses for pre-op and post-op. And fish oil was found not to increase bleeding risk and actually reduce the number of blood transfusions needed. So the higher omega-3 levels were actually associated with lower bleeding risk versus higher. And the next page here, I've got, this is one of the graphs from that study. And as you can see, some of the things that predicted bleeding or showed, higher risk for bleeding, age was a big one, smoking, diabetes, women were more likely to have significant bleeding. If you had an antithrombotic preoperatively, makes sense, getting blood thinner. The type of procedure was very predictive, of course. The more open you are, the more, cutting into you, there's going to be, they're more likely to bleed. But actually, the only factor that showed lower risk of bleeding was fish oil. This is one of several studies over the last, say, 5 to 8 years that have kind of put to bed that risk of bleeding with fish oil. So if you have, a practitioner that might be concerned, this is a great study to show them that bleeding we're not so much concerned about. Several other studies showing bleeding that this is a 2012 study showing that fish oil does not affect blood coagulation parameters and bleeding manifestations. This was a meta-analysis of 8 studies with 1,500 patients. This was assessed after an acute myocardial infarction, heart attack, and patients, again, with the highest omega-3s were actually at the lower risk. And this was omega-3 index. So this was using the omega-3 index as a measure of their omega-3s and looking at patients after they had a heart attack, which ones bled, which ones didn't through their surgical procedures. And the ones who were at the lowest risk for severe bleeding were actually the patients who were taking who had the highest omega-3 index, even though they were older and more likely to have a history of cardiac events. So even if you've got patients with those risk factors, having them, have that higher omega-3 index is beneficial. Okay. So interpreting results. All right. So those are, that was some of our, concerns, AFib and bleeding. Now we're going to talk about how to treat the omega-3 index and what to do with it. So this is what our omega-3 index report looks like. If you decide to, partner with us or, have your patients get their omega-3 index tested, this is what a results page is going to look like. So for this person, their omega-3 index is 6.0. They're kind of in that edge, they could be bumped up a little bit and get into that desirable range of 8 to 12%. So now we have treatment options, supplements versus food. As a dietitian and as a company that believes a lot in seafood, food is always better, but it's not always practical, especially depending on, location, socioeconomic status, just access in general. And then frankly, some people just don't like seafood. It's a pretty commonly disliked food, especially for, if you're in an area where seafood isn't as readily available in a fresh manner. It's just not always practical to recommend that people eat more seafood. So supplements can be a great option, but there are some important things to consider. And a combination of food and supplements is really the best we can do, aside from being, Japanese and eating, salmon or tuna every day since we're babies. That would be the ideal option. But if we're trying to get someone's omega-3 index up, if they're a little bit older than that, the combo of food and supplements is really, really highly effective. So for our fatty fish, eating fish every day or every other day in some cultures is common. Like I said, in Japan, they eat fish daily, sometimes multiple times a day, and they eat a lot of those high fatty fishes. But again, in the US, we just aren't necessarily getting that amount. But if you can encourage your patients to get some of those smash fish, the sardines, mackerel, anchovies, salmon, and herring, those are the highest and some of the most available options for fish. And even, using canned fish, even farmed fish is okay depending on the type. Even Atlantic salmon that's farmed is pretty high in DHA, is really, really high in EPA too, and still is going to provide a good amount of omega-3s and is still healthy to eat. Smaller fish tend to have lower levels of toxins. One group especially to consider here is pregnant women. And lactating women. There is a lot of mixed messaging around fish consumption during pregnancy, things like that, and especially for children as well too. There's a lot of concern around mercury. What we know is that when smaller fish have lower levels of toxins, so encouraging them to eat things like salmon versus a tuna are much larger fish. Encouraging them to consume those, those smaller fish, but also it does appear, some research has shown that mercury that is consumed through fish does not seem to have the cognitive negative effects that does when it's received from the environment, like if you're breathing it in, from an industrial environment or something like that. Not entirely sure why that is, but it does seem that mercury fear might be a little bit overblown in some, especially for that pregnant population. It's okay for a pregnant woman to eat fish if they can tolerate it. Just maybe not, shark or tuna every day. Supplements 101. So moving on to supplements, the fish is pretty straightforward. If you can eat fatty fish 2 to 3 times a week, you're doing way better than a lot of people and trying to get those high EPA and DHA amounts in. Supplements, the 4 things we want to consider with supplements are dose, form, consistency, and food. Okay. Dose is the number one most important factor in raising omega-3 index. The biggest number one thing I talk to people about is getting their dosage up. A lot of folks are taking 1 or maybe 2 gel caps of fish oil a day without looking at the supplement facts. And what they're seeing is the bottle says, 1,500 milligrams of fish oil, and then they turn it over and the EPA and DHA total is 300 milligrams, right? And they're only taking one soft gel, or when the serving size is 2, or the serving size is 2 twice a day, and they're only taking one once a day, or something like that. Dose is going to be the most important thing. There's a calculator on OmegaQuant.com that gives a good estimator of how much, based on your omega-3 index, that you need in order to get up into that 8 to 12%. It varies on a couple of factors, so I can't put it in here exactly how much you would need per, because it's pretty complicated. It varies, but the calculator is really, really useful. It's a good starting point. Not everybody is exactly the same, so I'll talk about that in a minute. Form. Dose is big, form is also big. So there are two primary types of fish oil out on the market. There's triglyceride form, and then there's ethyl ester form. If most of you are familiar with the prescription Lovasa, that's an ethyl ester form. Ethyl esters are a synthetic form of omega-3s, and they're not bad. Some people will kind of poo-poo all over omega-3 or ethyl ester forms and say that they're, not omega-3s. They are, and they do work for some people, but over time, triglyceride forms of omega-3s work just a little bit better, okay? And for some folks, a little bit better has a lot of impact. So form matters, and to some more than other, okay? So if you take this example here on the right, the normal responses to supplementation, these are two individuals who they started taking a supplement when their omega-3 index was found to be low, tested at 3 months and tested at 6 months, and they didn't change their form. They just got on a steady dose and they responded as you would expect. On the left here with Nate, we've got someone who did the same thing, started at that 6.28% and started taking 2,000 milligrams of ethyl ester form. It didn't move the needle at all at 3 months, no effect. So he was switched to a similar dose of a triglyceride form, and it had a huge jump. So for some reason, not entirely clear why, some people are a lot more sensitive to that form than others. So if you have a patient who they're like, I've been taking the right dosage, they're taking the proper EP and DHA, they're not just, looking at the fish oil dose and it's not working for them, switching to a triglyceride form might yield better results for them. That could be definitely a factor. Food is the next factor. So taking supplements with a high fat meal increases absorption. And this one is fairly significant, okay? So these both show taking a supplement with a meal and without a meal, okay? A low fat meal and a high fat meal. And as you can see here, the high fat diet, much better absorption than we see in this low fat diet here. Free fatty acids there, and this is the low fat diet. Okay, so a low fat meal, taking your omega-3 index with like a piece of toast is or taking your omega-3 pills with a piece of toast is probably not going to cut it. Adding something fatty to that toast, like some peanut butter or butter, eating something fatty like eggs, will increase the absorption of that as well. A lot of people like to take their fish oil, first thing in the morning when they take the rest of their supplements. Maybe they don't eat breakfast. And so that can definitely have an effect. So big question to ask your patients if they're getting frustrated and not seeing the results is, do you take it with a meal? Okay, food can make all the difference. Again, this is another example from our these are numbers from some of our clients. This is a person here, Lila on the left. She increased her dosage. So she started here at the 14 milligrams of ethyl ester, increased to 2,100. She changed her triglycerides. This guy, Frank, so this made a difference. This guy, Frank, over here, he changed and started eating with a meal and had a difference as well, too. So eating food can make a huge difference, and so can the form. And then last but not least is consistency. Being consistent with your fish oil supplement is probably one of the hardest things for folks to do, but is really, really important. I've had to, kind of drill down on this with several patients in the past, asking them, do you take it every day? And you'll get the people who will say, Most of the time, and when you really dig down on it, it's kind of when they remember, it's occasionally they take it twice a week and they're just not getting the amount that they need. They're just not consistent with it. So finding a time of day, a routine, kind of a way for them to remember to take it every day. The biggest issue I've seen with folks is they say, well, it doesn't make me feel any different. And that's why measuring is so important, because if they can see that their omega-3 index is being bumped up and they're getting that risk reduction, they're getting that benefit, then the fact that they don't feel any different when taking omega-3 supplement, it can be a motivator. Like, okay, I know this is affecting this number, because sometimes those things can be hard to motivate folks if they're not feeling this like huge jolt of difference in them when they're on the supplement. Okay, so a couple of clinical examples to wrap up here. So first one, just a couple of simple scenarios, responders and non-responders. Again, this is why, having someone who is kind of educated on this, if you're all healthcare providers, it's really great that you're listening to this, because knowing all of these differences can really help a frustrated patient who might be thinking they're doing the right thing, but they're really, off a little bit. So this first scenario is kind of our dream patient, right? This is a 55-year-old female. She's got a family history of cardiovascular disease, and she comes in, and you think, okay, let's check her omega-3 index, and it comes back at 3.5%, super low. So she, starts taking fish oil. You see her again in about a month. She says, I'm taking fish oil and I'm starting to eat salmon and tuna a couple of days a week. Great. So come back 4 months later, we recheck her omega-3 index and it's 8%. Huge jump. She was a responder. Great. So in this case, we probably would want to monitor annually, especially if she's going to kind of continue that level. If she's a patient who is really like new at this, really new at the dietary changes, it might be beneficial to do every 3 months for the first year to kind of make sure that she's staying on track, and then do every 6 months or just do it annually. But for her, she figured it out. We got her the right supplement. She's eating the fatty fish, all is well. So this next person, though, this is scenario 2. We got a 50-year-old male. He has a family and personal history of cardiovascular disease. He also has an omega-3 index of 3.5%. Reports starting taking fish oil, doesn't make any dietary changes for him. He just doesn't like fish. He retests at 4 months. He's all excited because he's been choking down these fish oil pills every day, but his omega-3 index is only 4.5%. And he's really frustrated. He's like, what the heck? I swear I've been taking it. So what's happening here, right? Questions to ask for him, right? Is he taking a high enough dose? I like to always make sure I can either Google the supplement if they don't know the name, or make them bring it in. Because a lot of times I'm taking 1,200 milligrams, I'm taking 2,000 milligrams. I swear that's what it is. And then you get the bottle and you realize it's a much lower dosage than that, because they're looking at the fish oil number, not the omega-3 number. What's the form of their supplement? It just might not be a very good supplement. And with the supplement market being what it is, the supplement may not have what it says it has in it. So getting them on a higher quality supplement, a brand that you may have worked with before, something that is a little bit better. One thing I always have to tell people is that they may be buying a supplement because it's cheaper, but I'd rather have you buy a higher quality supplement that costs a little bit more, that you don't have to take 10 of in order to get you a high enough dose. It's going to even out in the end anyway. Consistency. Are they taking it every single day? So has this guy been taking his every single day? Has he been taking it for the whole 4 months? Does he take his with a meal? And what is his activity level? So this is one I haven't mentioned yet, but activity level, high amounts of oxidative stress can really affect omega-3 oxidation and metabolism. So the higher your activity level is, the more oxidative stress you have, the higher your omega-3 needs will be to raise that omega-3 index. And then stress. Do they have any other significant stressors in their life, right? Are they going through a job change or a divorce or a move, or, had a new baby or something like that? Something going on where they're having a lot of significant stress, that can also affect omega-3 index levels, because you're utilizing more of those omega-3s. So for this case, this guy, you find out that he is frequently forgetting to take his supplement because he takes it in the morning. but he doesn't eat breakfast. So for him, a simple change of the timing with a meal and setting reminders. So maybe he needs to start taking it at dinner and sets a little reminder on his phone. Something as simple as that can make a huge difference for some of these patients, even when, because people, as we know, are not always great at reporting what they eat, reporting that they think they're doing it often enough, and they're really not. All right, so last example here, we've got a patient with low risk. So this guy is just someone who he's like really into his health, maybe a little biohackery type guy. And he's, 40 years old. He's got a BMI of 24. He's a triathlete, no history of CBD at all, no family history, really healthy diet. Reports taking fish oil and eats fatty fish, but wants his level checked. And then when he gets his omega-3 index, it's 5, and he's like, what is going on? So we ask all the same questions, right? And for this guy, the big indicator there is that he's a triathlete, right? He's super active. You find out that he's taking a poor quality supplement. So maybe it's something that his triathlon club, someone there was on or something like that. So he's only getting 500 milligrams of omega-3s a day. But he also has really high needs. He's training 15 plus hours a week for Ironman. So especially given his age, that he's in his 40s and he's training a ton, he has a really high oxidative stress level. He's probably going to need more than what a patient with that same omega-3 index without that level of activity is going to need. Having worked with a lot of military members, I saw that firsthand, that they required a much higher dose in a lot of cases than someone that might have been similar size, that might have had a similar number, but didn't have nearly the oxidative stress that they had. All right, so we made it kind of towards the end here. So our clinical wrap up, I just wanted to go through omega-3s, dose, form, consistency in food. If you are going to be talking omega-3s with any of your patients, if you're going to be, interpreting the omega-3 index, it's really, really important to consider those things when you're kind of correcting. Diet is always the first one we want to go to. If we can get more people eating fish, that's always a win. But we know that isn't always going to happen. So supplements can, be a lifesaver there. Omega-3s are not a fix-all for lipid panel concerns. Again, that can be really confusing for patients. It can be sometimes conflated because we're talking about triglycerides and LDLs and HDLs. People can get confused. And we say it's always helpful to check a patient's omega-3 index because of the strong relationship with all-cause mortality and cardiovascular disease. And with cardiovascular disease being the #1 killer of men and women in the United States and in a lot of Western countries, it is really important to check your omega-3 index, regardless of what their lipid panel looks like. Again, to show that one study where omega-3 index was more predictive and showed a stronger relationship to all-cause mortality and cardiovascular death than cholesterol. And so we're checking everybody's cholesterol all the time, when really we should also be checking their omega-3 index alongside that. I don't want to say instead of, because I think cholesterol is important as well, but the omega-3 index really should be checked in more individuals if we want to start. And especially here, living in a place where we don't eat a whole lot of fish. And if you're taking a diet history from someone and maybe they don't like fish, it's really important to check that, because it's highly, highly, highly likely that their omega-3 index is low. Okay. And again, you can't manage what you don't measure. All right. So last slide here. So I've talked all about the omega-3 index, but how do we do it at OmegaQuant? So all of our tests are at-home test kits. And there's kind of two ways you can do it. We are a direct-to-consumer company. So if you or any of your patients want to log onto our website and just order a test kit to do at home, they can do that. It's quick, it's easy. We send it to you. You collect a drop of blood onto a dried blood spot card, register your details, put it back in the prepaid envelope, and send it back to our lab. The lab analysis is done, and then we email the report to the patient. If you're a healthcare provider and you're interested in providing this test for your patients, we can set you up. I'll have contact information at the end of the webinar. We can set you up with a wholesale account, and you would kind of have a healthcare practitioner portal where you can see your patient's results and add this to your practice as well too. It's a really nice thing and doesn't require a doctor's order. So if you are a dietitian, or someone who doesn't necessarily have the ability to order labs, you don't need to have that ability for the omega-3 index. All right, so that is that. So I want to go ahead and open it up for Q&A before we wrap up.
Yeah, thank you, Kelly. That was fantastic. We just have a couple questions. One is, do you know of any studies showing results of people having 8% and 12%?
Asking if there's any benefit between 8 and 12%.
Yeah, just
a question.
I think so. Just the result, if there's a result difference.
Yes, so there does seem to be additive protection up to that 12% for the cardiovascular disease. There does appear to be increased protection up to 12%, but again, the diminishing returns happen after 12%. 8%, the increase from 8 to 12% isn't as great in protection as it is from a 4% to an 8%. So it's kind of why we set that lower threshold to be that 8%, so that you're getting that kind of minimum benefit, or maximum benefit, I should say. Yes.
Another question, if a patient's LDL is high and the omega-3 index is low, omega-3 supplements would still be indicated, correct?
Yes. Yeah. So again, an LDL, the increase in LDL is typically only seen if we have really, really, really high doses of omega-3s over a really long period of time. And it's also pretty rare to see. That doesn't happen all the time. So if you have an omega-3 index that is low and an LDL that is high, yes, omega-3s would be either from food or from supplements, or both in that case, would be indicated.
Is there a limit to omega-3 supplementation? 4 grams is the most this person has seen.
A limit from what we recommend? Yeah, usually we wouldn't recommend much more than 2 or 3 grams, depending on the person. It really all depends on the case, and depends on the person's, tolerable, like what they need. I have seen people taking upwards of 12 grams a day. That was in the setting of traumatic brain injury in a sports setting. So there's some studies out there showing 10 or 12 grams. There are different protocols for post-concussion protocols that have those levels. You're typically only taking that amount for a couple of days or maybe a week before you taper down. And that's just to get the omega-3 on board quickly. So in terms of an upper limit, not really. I mean, for most average people, for most folks that are just getting their omega-3 index done and want to increase their level, I'm probably not going to be having them on much more than 2 or 3 grams at most. That would be at most. But for some folks, depending on the situation, I've seen upwards of 10, 12 grams a day in certain settings.
Mm-hmm. Are there any contraindications to omega-3 supplementation if someone's prescribed certain medications?
Not that I know of. I don't know of any that would be contraindicated. I'll ask you, Christina, do you know of any that would be contraindicated?
The whole bleeding, like blood thinners, people are usually wary of big on omega-3s with those, but I don't believe they're officially contraindicated because the blood thinners are already thinning the blood to such a great extent. I'm not sure if the omega-3s would even matter. Right. But omega-3s as supplements, I don't know of any drug interactions. But we can check on that and follow up in our follow-up email. Just double check on that. All right. Can you speak to the PLUS test, which looks at the omega-6 omega-3 ratio and arachidonic EPA ratios and those supplementation requirements?
Yeah, so our omega-3 plus test, and then we have an omega-3 complete test. They just have varying amounts of information that you get, additional tests on top of the omega-3 index that you already get as our basic. So the omega-3 plus has the 3 to 6 ratio, the arachidonic ratio, or arachidonic acid, and I think that's it. Yep, EPA, DHA. So in terms of, was the question, supplements, is there any change? There probably wouldn't be any change for that.
Yeah, they said
Um,
looking at the ratios and I guess how you would use those to prescribe supplementation.
how would you use those? So the primary driver for driving supplementation would be the omega-3 index, because it is such a stable marker. The EPA and DHA might be interesting because a lot of folks sometimes, especially depending on the supplement, might be getting more EPA than they are getting DHA. So that might drive if you want to change your supplement to something that is a little bit more DHA heavy if you're getting too much EPA. As far as the ratio, the 3 to 6 ratio, there's not a whole lot you can do on the omega-6 side. Decreasing omega-6 in your diet doesn't really affect that omega-3 to 6 ratio all that much. What really affects the omega-3 to 6 ratio is upping your omega-3s, which is shown in that omega-3 index. That would be really your primary driver of what you would want to do there in the first place. So I would say it doesn't really provide too much, or it doesn't change too much of what we would want to do supplementation or diet wise. It is interesting though. I would say that EPA and DHA number can be really interesting, again, depending on, it can give you a little bit more information about the supplement that you're getting and such that way. But it wouldn't change too much of what you're doing on the supplement end.
Yeah, the omega-3 index is
It's the big one.
is the big one, and that usually
Yep.
everything follows that. If
Yep.
someone is already being supplemented, to get to a baseline, how long should someone stop the supplement to get a true measure?
So, this is an interesting question because kind of it begs the question, what is a baseline? If they've been taking the supplement for a long time, then I would say that their baseline includes the supplement, because that's what they've been doing for a long time. And I would say a long time is anything longer than, let's say, 3 to 6 months. If this is something someone's been doing for a long time, you want to know if what they're doing is working. If that's the biggest question, right? It's like if we went to Japan and said, we want to get a baseline on you, stop eating tuna. Well, that wouldn't be a baseline. Their baseline is what they do every day. So if it's someone who's been on the supplement for years, I wouldn't take them off of it. I would test it as they are right now, see where they're at, and adjust as needed. Maybe the supplement isn't very good. It's not doing what you needed to do, and change it. If a person just started the supplement, say a month ago, then I might suggest having them stop it because of the life cycle of red blood cells. You probably want them to be off of it for at least 2 or 3 months before you would get a true idea. But again, we're trying for a baseline. It's what is somebody already doing? That's really what a baseline is. But if they just recently started it, it probably hasn't had a like if they started it last week, I wouldn't have them stop it at all. They can take the test. It'll be fine. But if it's been like a month or two, that you might want them to stop it for a period of time. But again, a baseline is, an assessment of what they're doing right now, not, a blank slate, right?
Are there certain sports that require the higher doses of omega-3s?
Certain sports.
Yes.
I mean, it's probably all like volume related. So, endurance sports, especially those high endurance sports, I'm thinking like cycling, swimming, running, like those types of things where we're talking about hours and hours and hours and hours a day of training, really, really high volume, like distance running, ultra running. I'm thinking like, road cycling, like those types of things where it's really long training days. Those would probably where you're getting, you're doing that activity like consistently for hours all day. Those would probably be the highest because again, it's a dose response, right? You're having that higher amount of oxidative stress. And it's interesting too, there is some research on like football and the amount of stress and EPA and DHA requirements during preseason versus the season. Preseason is much higher intensity, practice days are longer, we have camp, all that kind of stuff. Is I believe is in college football players, and their oxidative stress was much higher during that time. So it's all volume related. I'd say those endurance sports are probably the highest, I would guess, but any sport, any time where your training volume is going to go up, your oxidative stress is going to go up, and your EPA and DHA, your omega-3 requirements will go up as well.
Great. Well, I think that's the end of the questions from my, I can tell. Thank you.
Awesome.
Yeah, that was great. Thank you guys so much for those questions and for coming to this webinar. We will be doing our next one. Do we have our next one up here? The next webinar?
So first, just a quick, this is our YouTube channel and our website. There's a lot more information if you want to look at some of our Omega Matters podcasts. That omega-3 index calculator that I talked about is on there as well as on our website. This is just out there for, and if anyone has any questions, there's my contact information. And then I put up our healthcare account educator, and he's also a dietitian, Tavis. This is his email. So if anyone has any questions, feel free to email either one of us. If you have clinical questions, I'm probably your gal. If you have sales questions or interested in getting signed up as a healthcare provider with us, Tavis is your man. And then our next topic, our next webinar is going to be on November 15th. And our topic is going to be omega-3s for pregnancy and breastfeeding, which is really exciting. So I'm looking forward to that one. And Christina is going to be presenting that one. So
It'll be fun.
But that's it. Yeah. Thank you so much for attending. It was really great to have everybody here. And that's all we've got.
Yeah, so we'll be following up with an email. Should have, as they're asking in the chat, we will have access to this. You'll have access to this recording, a CE credit certificate, I believe, a link to that, and a PDF of the slide deck. That's what we're planning on sending out to those who attended the webinar. So thank you all so much, and please feel free to let us know, email us about any ideas for future webinars or things that we could do better. So thanks so much.
Thank you.